Hi, it's Dr. Janelle. So now I'm going to talk about the second half of our reproductive years, which are the non-reproductive years. And let me tell you, if you haven't gotten there yet, I've been postmenopausal for 10 years now, and it is fantastic because no longer are you having those hormonal cycles every month. You're just like steady state. So it really takes some things off the table, and I'm starting to understand now why the whole wise woman, the whole crone thing. It's not entirely because you've lived an entire 50, 60 years and you have that wisdom under your belt, but it's also the hormones are off the table, and you might not be someone who can be messed with. So it's fun. Something to look forward to. So here's what's happening. Your brain, the pituitary, hypothalamic pituitary axis, has a cycle that's cycling with the ovaries when you're reproductive. So they're talking back and forth. The brain is telling you, okay, now it's time to make these hormones and get ready for pregnancy. So there's something called the FSH, follicle stimulating hormone, that your brain releases to tell the ovaries to do their job and release the progesterone and estrogen in the appropriate cycles. So follicle stimulating hormone and luteinizing hormone both are involved in that. When your ovaries atrophy, basically they shrink down to nothing, so now they can no longer produce any hormones. What happens is your FSH level goes up and stays up for a few years because your brain is like, hey, down there, let's make some hormones. But they're not listening because they're done. So you'll have an elevation of your FSH, and that's a great way to tell whether or not you are in menopause. It does elevate at some points during the cycle as well, so it's important to differentiate those. So your ovaries are now atrophied. You are no longer making progesterone or estrogen. So if you go to a doctor and you're postmenopausal and they want to test your hormone levels, you don't have anything to test. There's nothing there. So that's sort of a waste of your time. What's happening is that you don't have those hormones, and that's going to cause different types of symptoms for different people at different times. So it's important to work with someone who understands what those symptoms are and how to most safely manage your symptoms for you. So premenopausally, when you're still reproductive, deficiency of progesterone is the main problem. Postmenopausally, deficiency of estrogen is the main problem. That's what gives you hot flashes, night sweats, insomnia, vaginal dryness or vaginal atrophy, painful intercourse. What else is on that list? Those are the main things that I'm going to prescribe a bioidentical hormone for estrogen, because estrogen does have a risk associated with it. And that risk is not that it causes cancer, but that if there are latent cancer cells, either in the breast or the uterus, ovaries, if those are latent, then, and they're just kind of sitting there, the extra estrogens can feed that into that. So it's really important before you go on hormone therapy that you're up to date with your mammograms and you continue doing those on a regular basis while you're on the therapy. At that point, it's important to have your blood levels checked if you're on a hormone replacement. I usually do it every couple of months at first, and then we'll go, longer and just do it the annual exams. Because you want to make sure those estrogens are being converted into the healthier estrogens in your body, and your blood can tell you that through a standard lab. So the problem postmenopausally is you don't have enough estrogen. That's causing your vaginal skin to thin. That's causing hot flashes, night sweats. So if people have all those things and they're interfering with their day-to-day, then I will prescribe bioidentical hormone replacement in the form of estrogen. I'll always team that up with progesterone, because progesterone and estrogen work together. They're BFFs, and progesterone can mitigate some of the unwanted problems of estrogen, and that's mainly the cancer risk. So those together, monitor the patient. Now, in terms of the forms of therapy that you can do estrogen patches, replace them once a week. You can do estrogen pills and progesterone pills. You can do liquids. You can do pellets that last for 4 to 6 months. Any of those are options, and they all work. They all work fantastically. So that's really your choice between you and your physician. So we're going to get the estrogen therapy going. Sometimes people really don't want to do estrogen therapy, and so we'll try some of the more herbal and more natural routes. I personally have not had a lot of good luck with those. So I feel like if I'm monitoring someone and making sure they're staying safe and having their tests done, then I feel okay about having them on hormone replacement. If they don't do that, then I'm not gonna give them that medication because I want them to be safe and low risk. The other thing that can happen is that because you're taking estrogen postmenopausally, your endometrium, the lining of the uterus, might thicken. That's normal. I've had many times where someone has been taking HRT with me, they'll go to a gynecologist, and the gynecologist will lose their mind because the uterus lining is thickened. And I don't know, maybe they just out of school or something, but if your patient is on hormone therapy replacement, you are going to have a thickened uterus lining. And yeah, sure, go ahead and have a biopsy and make sure that there's no other problems going on. But I'll tell you, 99% of the time, the reason it's thickened is because you're taking the hormones. That's what they do. Not that you need a thickened uterine lining postmenopausally, but you need to sleep and you need to not have hot flashes and night sweats all day long. Okay, so that's one category of postmenopausal people. Another category are people that they don't have the hot flashes or night sweats. They might have some mood changes. They might have some just kind of more depression, anxiety stuff overall. So in that case, this person doesn't need to have estrogen replacement therapy. That's for hot flashes and night sweats. So that takes the risk off the table. So we can then use a combination of progesterone therapy or maybe progesterone and testosterone therapy, because testosterone postmenopausally for women, I've seen people go from so lethargic and so much body pain to feeling much, much better. Their energy's back. They don't have the aches and pains anymore. So testosterone therapy is actually a great option postmenopausally, and for some people perimenopausally, depending on what's going on. Okay, so I think I've covered most of that. Again, the forms are optional. You can get bioidentical hormone replacement therapy now from a regular pharmacy. Estradiol and prometrium or progesterone is the generic. So you don't have to go to a special compounding pharmacy. When you get it from a regular pharmacy, then it's going to be not as pure. It's going to have some, pharmaceuticals. They like to add the chemicals or colors and that kind of stuff. So if you're really, really sensitive, it's probably best to work with a functional doctor and get a compounded pharmacy version of what you need. But for someone like me, I've been taking the regular pharmacy version of prometrium, progesterone, and estradiol. Both are bioidentical for about 10 years now. And I will probably continue on with these. And obviously I do all the checks, like I said, and make sure, I have my testing done with my doctor. And I hope that answers all of your questions around hormone replacement, and I'm happy to answer any more that you might have. I want you to be a well, wise woman.